Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now look at the notes for Extract 1.
Extract 1, questions 1 to 12.
You hear a doctor in the A&E talking to a patient with chest pain.
For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Frank. My name is Dr. Norman. How are you doing today?
Not so well. Why else would I come to the A&E at midnight?
Yes, you do have a point. So, according to what you reported when you checked in, you are experiencing acute chest pain. Is this the first time you've had this type of pain?
No. I've experienced occasional stabbing chest pain over the last 2 years, but it usually goes away fairly quickly after a second or 2.
And has that pain been in the right or left side of the chest?
It's usually on the left side of the chest, but sometimes the position changes.
Generally, cardiac pain lasting a second or 2 is not significant. So what about today's acute pain? When did it start?
It started about 4 hours ago at 8 p.m. and has been persistent since then. It is here, in the centre of my chest.
And what about other symptoms? Are you experiencing shortness of breath or heart palpitations?
Nothing like that. It does feel a bit better when I sit up and lean forward.
Okay, I see. Speaking of feeling better, did you take anything for the pain?
Yes, at 9 p.m, about 1 hour after the pain started. I took 2 paracetamol, but it didn't seem to make any difference.
So let's just talk a bit about family history. Do you have any history of cardiac disease in your family?
Yes, my dad had a myocardial infarction at 51 and also had a high cholesterol level.
Well, that certainly increases the risk of heart disease, but I see no other risk factors evident so far. Okay, so have you had any other illnesses recently?
Yeah, about 2 weeks ago I had an upper respiratory tract infection. It lasted for about 4 to 5 days.
What symptoms did you have at that time?
The normal ones, sore throat, blocked nose, sneezing, also a really bad cough. The whole house was sick with the same thing, my husband and 2 kids.
So, I've taken a look at your electrocardiogram, and I think I have an idea of what is going on. You said that your pain gets better when you sit forward. This indicates a type of pain originating in the pericardium, the membrane that encloses the heart. Those 2 things combined with your recent upper respiratory tract infection points to pericarditis with a viral etiology.
Okay, so what is that exactly? Is something wrong with my heart?
So pericarditis is swelling and inflammation of the membrane surrounding the heart. In many cases of pericarditis, the cause is unknown, but one common cause is viral, which can be caused by a cold or pneumonia.
So is this serious? Will I need to be admitted to the hospital?
No, I'm not recommending that you be admitted at this time. There is some risk for bleeding into the pericardial space, but for now, I'm going to recommend rest and NSAIDs. You need to get another electrocardiogram in 4 days. By that time, your symptoms should have cleared up, and we will want to make sure that the ECG shows that everything has been resolved.
Extract 2, Questions 13 to 24.
You hear a neurologist talking to a patient who has had a traumatic incident.
For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Jack. My name is Dr. Farrow, and I'm here to conduct a neurological assessment. How are you today?
I'm doing okay. Nice to meet you.
So, they tell me you've just had an accident playing football. Do you know how long ago the accident happened?
Yes, just about 6 hours ago. I crashed into another player. They tell me I hit the right side of my head against his knee, but I don't remember any of it. He must have jumped pretty high for his knee to hit my head.
Yes. I can see here that you then fell to the ground and were unconscious for 20 to 30 seconds. So you continued to experience amnesia about the event?
Yes, I remember running towards the guy and then, nothing. Black. But then I woke up later and felt absolutely fine for a while. I was chatting with the nurse and trying to convince her to let me go home.
So after you arrived at the first facility, you had a generalized motor seizure and were given lorazepam to stop it. And I can see the CT scan done then was unremarkable. I can see now that you are having slight psychomotor slowing and some slurred speech. This may be because of the lorazepam. How are you feeling in general?
I'm a little nauseous. Also, I have a headache, but that is probably to be expected, right? I hit my head.
Maybe. But I want to get another CT, a non-contrast CT of the cranium, and to keep you under observation as deterioration can be quite rapid in these cases.
In what cases? What do you mean deterioration can be rapid?
You described a lucent period before your seizure, which is a classical presentation of an epidural hematoma. Also, the fact that you then had a seizure and are showing a downward course with more neurologic problems is another sign that concerns me. And the symptoms you just described to me are also associated with this condition.
Okay, but what is an epidural hematoma?
An epidural hematoma refers to the accumulation of blood between the inner table of your skull and the outer dural membrane, which is the outermost layer of dense connective tissue surrounding your brain and spinal cord. This condition is generally caused by a traumatic event involving a blunt object, such as getting hit in the head by someone's knee while playing football. It often results in an overlying fracture of the skull. It is the blood vessels in close proximity to the fracture that are the source of the hemorrhage or bleeding. I do need to tell you that there are other possibilities.
What other possibilities? Are they worse?
Other possibilities are a subarachnoid hemorrhage and subdural hematoma. For these two, a lucent period is not expected, but the CT will help us to determine what your condition is. For now, the most likely diagnosis is epidural hematoma.
Does it mean permanent damage? Will I be able to play football again? My mum is already going to be pretty upset with me about this injury.
Generally not, because the underlying brain is usually minimally injured. Prognosis is excellent if we treat it aggressively. Also, you were brought in right away, which increases the chance of a good outcome. Of course, it also depends on what type of epidural hematoma you have. As for playing football again, we can talk about that later.
I really hope I can continue to play. I'm not that good, but I love the game.
Like I said, we can talk about that later, but first...
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear a conversation between a GP and a urologist.
Now read the question.
So, Dr. Jones, I'm calling about the patient I'm referring for a neurologic assessment.
Yes, Dr. Salomon. Is this the patient with the weakness and wasting of the muscles of his left hand?
Yes, in addition to the wasting of muscles in his left hand, he also has noticed cramps in his forearm muscles. The weakness and cramps are most marked after exertion. I also noticed in his last appointment that he has developed some fasciculation in the muscles of the upper arms. It is all there in the notes, but I just wanted to touch base because I'm quite concerned about this patient.
Okay, I have seen the latest blood test results. I will give you a call after I conduct my physical examination. The patient made an appointment for...
Question 26.
You hear part of training on handovers between nurses.
Now read the question.
So Dr. Alex is here today to present additional information about our system of handover between nurses. Thanks for joining us.
Yes, thank you very much for having me. So, as we have seen before, the flow of the handover is patient details, presenting complaint, significant history, treatment and plan. Each part of the handover should be brief and relevant. For example, while going over the presenting complaint, it is not necessary to go into all of the details on the chart. You only need to go into details related to the patient's significant medical history. For example, today around 10 a.m., this patient's breathing became worse than normal. His wife called an ambulance. This patient has a history of emphysema and is under treatment by the respiratory team and is on home oxygen 24 hours a day. Now, the details that you give while discussing treatment can include what has been done with the patient, as well as any important details, allergies, and family dynamics. Next, we are going to...
Question 27.
You hear a morning briefing on a ward.
Now read the question.
Okay, so we have a patient who was admitted last night following a visit to the A&E due to a sudden development of difficulty with speech and weakness in the right arm and leg. Neurological examination showed an alert patient who could follow some simple commands, but with severe impairment of word fluency, naming and repetition, and severe weakness of the right upper extremity. An electrocardiogram revealed atrial fibrillation. The current diagnosis is acute cerebral infarct, but a head CT scan is needed to rule out an intracerebral hemorrhage and to confirm diagnosis and start therapy. We also need to get additional laboratory studies, including a complete blood count, glucose, prothrombin time, and partial thromboplastin time.
Question 28.
You hear part of a training about sports nutrition.
Now read the question.
So, today's training will examine how poor nutritional intake affects an athlete's ability to train, recover from training, compete and continue to compete. Dietitians can play an important role in supporting general practitioners and athletes by doing a full dietary analysis to help make recommendations for short, medium and long-term health and training goals. So, we will start off by looking at a case study of an athlete training for a trail marathon. The athlete wanted to assess his macro and micronutrients to ensure he was obtaining good nutrition. Based on his training regimen, we calculated that his daily caloric intake should be between 3,060 and 3,363 kcals, which was higher than what he was currently taking in. As far as macronutrients, we found that he needed to increase his intake of carbohydrates and lower his intake of fats. When we looked at vitamin and mineral intake, it was mostly meeting the required levels, apart from vitamin D. So we recommend...
Question 29.
You hear a trainee doctor asking a senior doctor about a patient's chest X-ray.
Now read the question.
Dr. James, I have a question about the 19-year-old boy's diagnosis.
Okay, have you taken a look at the chest X-ray?
Yes, I have. I can see that both upper lobes are marked with ring and tubular shadows, representing thickened bronchial walls. Isn't this finding consistent with a diagnosis of bronchiectasis?
Yes, but the prominence of the pulmonary arteries in the chest X-ray indicate a degree of pulmonary hypertension. Also, the medical history is quite important in this particular case. The patient has a long history of repeated chest infections.
Yes, I hadn't considered that part.
Question 30.
You hear a conversation between a GP and an office manager about staff burnout.
Now read the question.
Wow, what a long day.
Yes, Dr. Phillips. There have been quite a few long days since that practice down the road closed all of a sudden.
Definitely. I mean, we have taken on an additional 3,500 patients.
Yes. We thought it was going to be a temporary situation, but we've only been able to relocate about 500 of those patients to other practices.
Yes, and some of the new patients have complex health needs. I mean, we used to have a waiting time well below the national average, but now our patients are waiting longer and longer.
Yes, and I have noticed that many of the doctors are experiencing their own stress-related health problems. I mean, what can we...
Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36.
You hear a presentation about the role of general practitioners in the care of older adults.
You now have 90 seconds to read questions 31 to 36.
Hello everyone. First of all, thank you very much for attending this session on the role of general practitioners in the care of older adults. As we all know all too well, general practitioners and their practices are facing unprecedented challenges relating to staff burnout, finances, and an increased workload. Today I'm going to present research highlighting the challenges that general practitioners face, as well as the importance of general practitioners in the care of adults. To start off, I'm going to give an introduction to the study. Serious infections diagnosed in adults aged 65 and over are the leading cause of hospital admissions and are associated with high mortality. Detecting the presence of serious infections in older patients is often difficult due to a variety of reasons, including atypical presentations and non-specific signs of infection. For these reasons and others that we will explore in a moment, distinguishing which older patients have serious infections remains an important challenge for general practitioners. In order to better understand the issues that general practitioners are dealing with in this area, we conducted a research project that involved doing interviews with 28 different general practitioners and analysing the themes that came up. The GPs interviewed represented a variety of experience levels, GP roles, and practice populations. Interviews involving discussing patients as well as general observations about a variety of topics. The first theme involved challenges that lead to diagnostic uncertainty. The first of these challenges identified was patient complexity. GPs described how assessing acute illness in older people was frequently confounded by the background of multiple complex medical and social needs. For example, several GPs mentioned how multi-morbidity and polypharmacy could affect interpretation of assessment. As one GP said, a tachycardia, which would be a measure in many other patients, isn't a very good thing if someone's on beta blockers, or if they have a pacemaker. Another aspect of this theme is the lack of knowledge of the patient. GPs cited the lack of sufficient background information or perceived lack of continuity as a particular challenge in this context. GPs reported the importance of knowing how well a person is getting around, whether they're talking the same way, whether they're confused more, among other changes in a patient's condition, and said that it has become more difficult to know their patients well. This was particularly relevant for locum GPs. One GP mentioned the increases in GP workload as a barrier to following up with patients. This pressure on GPs' time has also greatly reduced the capacity for home visiting. Another theme that emerged were approaches to recognize suspected serious infection in older adults. One sub-theme here is the difficulty with obtaining patient history, as older patients can sometimes experience confusion or dementia, or there can be challenges with communicating with older patients. GPs also reported difficulties with relying on vital signs in older patients. For example, while a high temperature would confirm infection to a GP, a low or normal temperature was not necessarily reassuring. Similarly, GPs reported relying on different signs to detect infection in older patients, such as respiratory rate, oxygen saturation, among others, and not always feeling that any of the methods were particularly reassuring. When it came to managing diagnostic uncertainty, GPs reported ordering a wide variety of investigations with different levels of perceived reliability. For example, the use of urine dipstick testing was widely reported, but interpretation was often problematic, particularly in catheterized patients. In addition, the practicalities involved in obtaining some tests limited their use. One GP said that if she wanted blood tests, she knew it would be a day or two for the blood to get drawn, and then another day or two for the results to come through. This delay often resulted in GPs making decisions without getting blood tests. In conclusion, challenges to diagnosing older people with serious infections are present at each stage of the patient assessment. such as taking medical history, which is frequently disrupted by communication difficulties, due in part to cognitive impairment and confusion, as well as during the physical examination, which is not believed to reliably predict the severity of disease in this age group. Another conclusion of this study is the impact of losing continuity of care for older patients. Previous research has shown that long-term, high-quality primary care relationship is particularly important for this age group, especially when it comes to decreasing emergency department visits and unplanned hospital admissions.
Extract 2, questions 37 to 42.
You hear an interview about extended roles in dietetics.
You now have 90 seconds to read questions 37 to 42.
So I have with me here today Kaylee Flick, a registered dietitian who works at a local hospital as a critical care dietitian. Welcome to our program, Mrs. Flick.
Thank you for having me. It is a pleasure to be here to talk more about the field of dietetics. We dietitians are a small profession, so it is particularly important for us to share our journey to move the profession forward to inspire the next generation of dietitians.
So, as I just mentioned, you currently work as a critical care dietitian. Tell us a bit more about this role and how it shows that the role of dietetics has changed.
Yes, so as a critical care dietitian, I work as part of a care team providing care for critically ill patients. This includes identifying patients at nutritional risk, advising on evidence-based nutritional treatment plans, and making decisions about feeding methods. Nowadays, many dietitians are playing extended roles within clinical practice. Many roles that were traditionally held by nursing or medical professionals are now held by dietitians working beyond their recognised scope of practice.
Interesting. So, what has given rise to this change?
Originally came about as part of an effort to modernise the NHS and to transform healthcare services. This involved extended roles for some allied health professionals, such as dietitians. We've seen that it has boosted job satisfaction, improved the dietetic profile, enhanced multidisciplinary team learning, and most of all, it has provided better patient care. It is important to remember that allied health professionals are the third largest workforce within the NHS. So it is important to look for ways to develop more advanced clinical practice posts that take advantage of their expertise and skills.
So, with these extended roles, are dietitians working with more complex cases?
Yes, we're certainly seeing dietitians take on more advanced practice. A couple of months ago, there was a patient at my hospital whose care team included 2 specialised dietitians. One that worked in the ICU and the other one was a bariatric dietitian. The patient who had had bariatric surgery 8 years ago was in a car accident. The ICU dietitian completed an initial assessment and made decisions about the feeding options, and the bariatric dietitian was called in as an expert on filling and adjusting gastric bands.
That is so interesting. I would never have thought that dietitians would be involved with those aspects of patient care.
About 20 years ago, it wouldn't have been the case. These complex cases and expanded roles of dietitians are part of the reason the British Dietetic Association has taken the important step of putting together 4 pillars of practice that all advanced practitioners must take into account as they develop throughout their career.
It is great to hear there is some framework to guide this transition into advanced practice. Can you tell us a bit more about these pillars?
Of course. So the first pillar is advanced dietetic practice, and it refers to the demonstration of expert knowledge and skills and the management of a complex caseload. The next pillar is related to research and evidence-based practice, and third pillar encompasses leadership and management. As an important part of a multidisciplinary team, it is necessary for dietitians to demonstrate the capacity for shared leadership.
Yes, I would say that is an important competency for all healthcare professionals.
Yes, of course. And the final pillar is related to education and facilitating learning. Dietitians should facilitate the learning of others, actively contribute to specialist groups, and undertake professional development, such as including reflection and feedback in their practice. Of course, the contributions from each pillar will vary depending on the type of job a dietitian holds, such as clinical, research, or work in the private sector.
So, what is next in extending roles for dietitians?
Well, there has been a change in the way that the NHS thinks of allied health professionals. There is still a lack of funding for dietitians in many areas of clinical practice. Despite evidence of the benefits of having a dietitian as part of the critical care team, no unit in the UK has full-time dietitians. The same is seen in Australia and New Zealand, where only 25% of units have weekly dietetic hours. As you can see, adequate funding is required to ensure consistent and established dietetic input.
I see. As with many other areas of healthcare.